Good morning, everybody. I see some messages coming through about whether we've started yet. Apologies for the short delay. I hope that everybody can hear me now. Thank you, first of all, for joining us this morning for the launch of the Health Reform Report. It's a report that Section 27, together with Concentric Alliance, have worked on, including through interviews over the last year, and we're really excited to share this report with you. So the way that the session is going to work is I'm going to do a short introduction to the report so that everyone can see what it entails, and then we're going to have hopefully an exciting panelist discussion followed by some Q&A. So please, if you have any questions or comments, feel free to put them either in the normal chat or in the Q&A box, and we've got people monitoring those. And you can see the link to the full report has already been posted in the box. Let me start with the presentation of the report. Sorry, I'm just trying to get it to start slideshow. There we go. So this is our report. Where are we now? We started off, the reason we started to do this research is because of a recognition that something needs to change. And where we are now really isn't a matter of much surprise. It's something that's in the news quite often. We have real stagnation of health reform efforts while we're waiting for the NHI bill. The NHI bill has been a topic of discussion for many years. And in the interim, while we've had 5 years of pilots that we were then told were not NHI pilots, we've had some interventions, including amendments to the National Health Act. We haven't seen the kind of health system reform that is so desperately needed in the country. We also have a very low trust environment where the different parties, the different stakeholders have spent a long time engaging with each other and now distrust each other's motives and interests. We have, as we all know, a health system under severe strain, whether that's for patients trying to access medication or oncology or other services, including primary healthcare services, or for healthcare workers who are propping up a system that is under real pressure and who are themselves facing significant pressures, including from administration that is trying to tamp down dissent. And as a result of that, we have the loss and threatened loss of healthcare workers, something that we can ill afford in a country where we already don't have enough healthcare workers. And indeed, there's a global shortage of healthcare workers. And so we certainly can't afford to lose any of the health workers that we have. So what did we do? We decided that we needed to speak to people confidentially. There's a lot of discussion and debate publicly. There are a lot of public statements. There are a lot of positions. And those positions make it look like everybody is quite far apart. Like you're either for NHI or health systems reform or you're against it. And we wanted to see whether that was indeed the case when we speak to people confidentially and try and find out what they think about health systems reform and what is needed. And so we interviewed 33 stakeholders from across the health system. We spoke to people from national and provincial departments of health. We spoke to health regulators, people from medical schemes, public and private healthcare workers, trade unions, people from private hospital groups, people in academia, people in civil society, those in the pharmaceutical industry, and those in government more broadly. We read submissions and statements on the NHI bill and health reform from the last few years. And we found that there were some real barriers to engagement that various people identified. The first barrier, and it's a significant one that I've mentioned already, is a lack of trust. And that lack of trust is from all sides. Many of the stakeholders that we interviewed distrust other parties within the system. Part of that distrust is because of concern about vested interests and about ideology and a perception that there isn't a good faith effort to improve the health system and therefore access to healthcare services by other people, by people on the other side of the arena. And there's also a real perceived lack of leadership, and that's from within government, but also within the private sector, within civil society, within trade unions. There's a feeling that those who should be taking the lead and should be helping to formulate consensus are failing to do so. So those are some of the barriers to engagement. So what then did we find? Now, as I said, this is often a debate that seems very polarized, but we found some really amazing areas of agreement. And particularly, we found that everyone that we interviewed agreed on certain things. Firstly, everyone agreed that the foundation of the health system is the right to access healthcare services. Now, that may seem normal for those of us in South Africa because we're used to talking about the Constitution, we're used to talking about the right to health. But globally, this makes us a real outlier, and it's something that we need to leverage and to lean on in our health reform debates. Everybody agreed that the right of access to healthcare services should be the center of the healthcare system. Secondly, absolutely everyone agreed that there's a need for health systems reform, in part to realize the right of access to healthcare services. Now, again, we often hear that some people just don't want anything to change, and that's the reason why the health systems reform attempts haven't been pushed forward or they're being blocked. But what we found is that really everyone thinks that there is a need for health systems reform. So that's another important foundation on which to base efforts moving forward. Thirdly, everyone agreed that there are governance, management, and accountability issues that need to be addressed urgently, again, across public, private, trade unions, civil society, and academia. Again, important, there is a real acknowledgement that there are issues when it comes to governance, management, and accountability that need to be resolved. And finally, everyone agreed that there's a need for and the possibility of collaboration. Now, we often hear talk of collaboration, but we don't see it. And part of the reason we don't see it is that, it's perceived that really we don't think it's possible. It seems in this case, it seems in relation to health systems reform, that there's a recognition of the need for, and there's a recognition, importantly, of the potential of, or the possibility of collaboration for health systems reform. And then we had other areas of agreement that many of the participants noted. Very importantly, many agreed that there's a need to try different mechanisms. So to test out different ways of harnessing private sector capacity to service the public sector. So many agreed on that. And that there's a need to try different mechanisms for establishing the systems to support a more rational referral process. So those are two areas that give us real potential for change, and that there was a large degree of agreement on amongst participants. Many participants also agreed that we need to monitor health outcomes better and orient our health system to respond to those outcomes. So again, seeing a health system as part of the need to realize the right and therefore to respond to people's needs rather than just being a system. So part of this is about data collection and monitoring, and part of it is about orienting the health system to respond to the needs that exist. And finally, and also importantly, many of the respondents, including respondents in the private sector and the pharmaceutical industry, agreed that the private sector and the pharmaceutical industry need to be better regulated. Now, of course, what that regulation entails is not a matter of agreement, but there is recognition that there needs to be a different and better regulation of those sectors. And what we find really is that this gives us a lot to work with. Some of these areas of agreement were surprising to us because it doesn't seem from the public debate that there is such agreement. But what we see is that there seems to be a real opportunity to take tangible steps now on the basis of consensus towards health systems reform. There are things that we can do now. But then what were the areas of disagreement? Now, these will be less surprising to everybody because this is what we hear a lot about. There was real disagreement about the roles of medical schemes and particularly about what the NHI foresees the role of medical schemes being eventually, which is to provide only complementary cover, so only cover for health services that aren't covered under the National Health or through the National Health Insurance Fund. Interestingly, there was also disagreement about how to produce and keep sufficient and appropriately qualified human resources for health, a really difficult and wicked issue that there's much concern about. And there wasn't much concern about, and there wasn't agreement on how to do it best. Another area I'm going to come up against, but in the beyond NHI and the health systems reform, when it comes to finally, there was some disagreement about the appropriate governance of funds and facilities. So what were the recommendations? We have the recommendations were that we take action along two paths. And I should say firstly that these two paths are not intended to be seen as sequential. So it's not that the first path must be completed and then the second path must start. They're not intended to be alternatives to each other. And then also not intended to be alternatives to the National Health Insurance legislative process. This is really about health systems reform beyond NHI, whatever happens with NHI. The first path was that it was clear from the responses of the participants that there is appetite for and a need to take action in areas of consensus. There are things we can actually do and that we can actually do now that will improve access to quality healthcare services now, and that should also build trust in health systems reform and between stakeholders. So some of the areas of consensus in which it would be possible for us to take action include the following. The first is about piloting contracting and referral mechanisms and experimenting with different options of delivery. So an example could be in Gauteng, for example, where at the moment, there are about 2,000 people waiting on the radiation oncology waiting list at Charlotte Maxeke due to various reasons, not just the fire and COVID. And there is excess capacity within the private health sector in the province to take up some of that slack and to be able to cater to the people on the list. And there's interest within the private health sector in doing that. That could be a good pilot for seeing how cooperation and collaboration between public and private health sectors could work. And there may well be others, including, for example, or in addition to that. So firstly, it's about piloting, and we could pilot either at district level, and there's some interest among some participants in doing district level pilots of specific interventions. And importantly, not just doing the same thing in a variety of districts, which is what we did with the initial pilot districts, but testing different interventions in different places to see what actually works, what kind of payment mechanisms work, what kind of referral mechanisms work, etc. There's also interest in doing this potentially in one or two provinces. So there are different options, but there's a real appetite for piloting alternative interventions that could improve access to healthcare services now and test how different interventions could work. The second area of action that we could take is in relation to national health projects. So not piloting at a provincial or district level, but looking at projects nationally where there could be collaboration with the private sector and where new interventions could be implemented across the country. And some of those that were mentioned included ICT systems, procurement systems, infrastructure, and logistics management. There's a lot of expertise within the private sector and interest in collaboration there. But there's also a need to have a standardized system across the country. And I think some of this is in fact happening already, but there's certainly interest in it being extended. The third area of action that we can take is identifying and measuring health outcomes and indicators across all health facilities. So I mentioned before the importance of data collection and analysis, and orienting the health system to focus on health outcomes. It was mentioned by many of the participants that something like pre and postnatal care would be really good candidates for this kind of health outcomes monitoring and orientation of the health system, and that this could happen across both public and private health sectors. So it shouldn't just be a public thing or a private thing, but really that it should be a project across both sectors, because in this way we orient the health system to respond to the needs of people. The fourth area of action is implementation of key health market inquiry recommendations. So there are some recommendations within the health market inquiry report that many participants think would be useful to move health systems reform forward, and there is quite a significant degree of consensus on that implementation. At the moment, there's been no implementation of any of the recommendations of that really good and evidence-based report, which is both a waste of money and potentially a waste of opportunity, according to many of the participants in this research. And the final thing is consideration of procurement reform. There are ways of changing the way that we do procurement that many of the participants in this report thought could be implemented on an urgent basis to improve access to services across the country. And so these are some of the things that we can do now. These are some of the things that can improve access now and that can be implemented now. And in doing so, we are able to provide proof of concept. We're able to show where health system reform can happen, and we're able to build the kind of trust that's required for further reforms. So that's the first path that comes within the recommendations in this report. The second path is about consensus building on areas of disagreement. There are real areas of disagreement that are well known and that we further uncovered within this report. And because health systems reform requires a lot of stakeholders and a lot of buy-in, it's very difficult to make it happen by fiat, make it happen through legislative change. And what we think, based on the input of the participants, will be needed is a consensus-seeking process that brings parties together on the basis of certain principles to discuss some of the more difficult and contentious issues and how they can be resolved. And some of those issues include the roles of national and provincial departments of health, the roles of medical schemes, and human resources training and retention. And Brian will speak in a moment about what that consensus-seeking process could look like. So where does this take us then? I think what we found really heartening is that the public debate on health systems reform is not nearly as dichotomous and simplistic as it's often perceived to be. People are not either for or against health systems reform and should be written off, depending on which side of that aisle they fall. In fact, the views that people express when they're outside of the public eye are much more nuanced, less dogmatic, and less ideological, and much more solutions focused. We think that the findings of this report are encouraging because they illustrate that there is hope for health systems reform beyond the current impasse. And we hope that the findings and the recommendations of this report, together with the discussion that we'll have with the panelists now, can help to move us towards a health systems reform process that is action-oriented, that provides solutions now, and that provides a pathway for further health systems reform. Thank you.
Good morning, all. I sincerely regret that I can't be with you today. Ironically, I was at the last minute brought into the launch of a consensus building process in the mining sector happening at this very moment. Consensus building, also known as collaborative problem solving, is a conflict resolution process used mainly to settle complex multi-party disputes. It allows multiple stakeholders, parties with an interest in the problem or issues, to work together to develop a mutually acceptable solution. While everyone may not get everything they initially wanted, consensus is reached when everyone agrees they can live with whatever is proposed after every effort has been made to meet the interests of all stakeholding parties. Most consensus building efforts set out to achieve unanimity. However, although preferable, that is not always possible or even necessary. In such cases, it is acceptable for a consensus building effort to settle for overwhelming agreement that gets as close as possible to meeting interests of every stakeholder, what we called sufficient consensus during our CODESA multi-party negotiations. And there are many examples, both in South Africa and internationally, of successful consensus building, some of which I've had the privilege of being part of. For example, during our transition period between 1990 and 1995, I facilitated a successful consensus building process in the political and spiritual capital of apartheid, Pretoria, between the Nationalist Party, the African National Congress, the PAC, Progressive Federal Party, and other parties for the establishment of a transitional Tshwane Metro at a time when mentioned that Greater Pretoria might change its name to Tshwane was treasonous amongst the Pretoria establishment. A few years later, after the birth of our constitutional democracy, at the Union Buildings, I facilitated a consensus building process for the establishment of a single Department of Foreign Affairs, incorporating the Apartheid Department, ANC missions abroad, and, believe it or not, the so-called TBVC states, Transkei, Botswana, Bophuthatswana, Venda, and Ciskei, all of which had full-blown embassies in Pretoria. Consensus building as a process is becoming increasingly relevant in today's interconnected and symbiotic society, where success is dependent on collaboration between diverse stakeholders, ostensibly with conflicting interests and needs, but are not necessarily irreconcilable. What we are increasingly witnessing in today's world is the need for collaboration between the public and private sectors. When, as problems mount, in dealing with society's problems, they rely, or at least should rely, on each other for help to achieve the best outcome. The parties affected by decisions are often interdependent as well. Therefore, it is extremely difficult and often ineffective for any single party to try to resolve complex and controversial problems on their own. Very importantly, stakeholders in the public and private sectors, and in this instance, the health system, possess a wide range of understandings and perceptions of the problems and of the solutions. A consensus building process helps to establish a common understanding and framework for developing solutions that would work for most and would permit stakeholders to deal with interrelated issues in a single forum. This allows stakeholders to make trade-offs between different issues and allows the development of solutions that meet most people's needs more completely than decisions that are made without such widespread participation. But what is the reality in the health reform debate in South Africa today? Whilst our research has illustrated that there are in fact many shared principles that the National Department of Health and the private health sector hold on health reform, the way the debate has been pursued so far has resulted in worsening relationships, a breakdown of constructive dialogue, and a stymieing of responses to one of South Africa's most important challenges: the realization of a fundamental human right entrenched in our Constitution, equity and access to quality healthcare for all in South Africa. There have been attempts to bring these parties together in dialogue, most recently during the government's Presidential Health Compact in 2019. However, during our interviews, many participants argued that while the intent was good, the process was not consensus-based, but rather sought the acquiescence of stakeholders to government's position. Many of those we interviewed felt that the participants of the compacting process were selected for their compliance and that the process failed to address the fundamental challenges in the health system and excluded many stakeholders. Engagement also failed to be sustained much beyond 2019. The public debate on health reform and the NHI bill has become deeply contentious, creating a false dichotomy of those who support NHI and those who do not. In truth, the distinction is not nearly as clear-cut, and many supporting the fundamentals of the bill while being deeply concerned about how NHI will be implemented. Notably, Adrian Gore recently stated the moral imperative for the NHI. There are also those who support the intent of the bill but believe that much more needs to be done to reform healthcare than is presently contemplated in the NHI bill. The lack of nuance in the public discourse has meant that major stakeholders are speaking past each other, that important and relevant points have been lost in a debate that relies on expertise, and that the level of rhetoric is contributing to uncertainty and a lack of trust in government and other stakeholders by both practitioners and users of the health system. So how do the stakeholder representatives extricate from that quagmire, which is slowly but surely suffocating meaningful engagement? The victims of which will be all of us, but once again, those who will suffer the most will be the poor, the vulnerable, and the disempowered. Shame on us. Now, having identified areas of initial consensus through this research, so-called low-hanging fruit can be targeted for action. And there are surprisingly many, many more areas of consensus than one would have expected. But what is the way forward where there is little or no consensus? Every participant interviewed during the process agreed that there is an urgent need for health reform in South Africa. That is very significant. However, each participant has either expressed sentiments that indicate a lack of trust in other stakeholders, an acknowledgement that parties often treat each other as adversaries or are simply unwilling to compromise. One may ask, is the conflict primarily a consequence of fundamental substantive differences on healthcare reform, or primarily the result of a huge trust deficit? If the stakeholders don't engage in a consensus-building process, we will never know. Either way, through the process of interviewing key informants, we believe there are windows of opportunity for engagement that undoubtedly could strengthen the health system and serve as a basis for further future collaboration. While consensus building on health reform will by no means be easy, there seems to be agreement from nearly all participants that they are willing, notwithstanding the reservations, to attempt dialogue. Having said that, the very act of coming together to explore in detail consensus building would be an important and critical step and would take a great act of faith from the parties that have experienced a considerable deal of disagreement and who often distrust each other. Are there risks in engaging in consensus building? No, there are not. It is not a negotiation towards a settlement agreement with or without prejudice, with or without mandates. This is not about government surrendering power or about the private sector taking power away, or such a process usurping the role of Parliament. Furthermore, the agreement to participate in consensus building does not require the abandonment of support for the NHI, nor should it require full-throated acceptance. That is not the nature of consensus building processes. Rather, it is a process that would acknowledge that there are questions to ask about NHI, not least to dispel the current damaging level of uncertainty and real challenges in the health sector that need to be addressed. While acknowledging there is, in fact, serious resistance to the policy as it currently exists, there are opportunities to explore and strengthen both the NHI model and the health system more broadly through a collaborative effort. At this stage, however, it would be impossible to say whether a consensus-building process on health reform would work or not. Nevertheless, there seems to be enough support for the idea from those interviewed to make it worth exploring. This is particularly true in the context in which we find ourselves currently. The process would have to explore and agree on the challenges that are currently facing the South African health system, a task this report has only started to do by raising the most contentious aspects of health reform and looking at those where there might be opportunity for early collaboration. It would further require an agreement to discuss issues in an environment where there are deeply entrenched beliefs and important interests that have a role in the health system. There's also the pressing reality that reform of the health system is becoming a critical requirement for South Africa. The challenges are mounting and the failure to act could have a devastating impact on the country. Assuming there is agreement to participate in a consensus building process, the process would need to be carefully designed, creating opportunities for wide participation, detailed problem solving, and for parties to come together in a way that they feel heard and included. We believe that the route to doing this is to bring together actors from government, the public sector, the private sector, trade unions, academia, and civil society to co-design a consensus-building process. Thank you.
Good morning, everyone. My name is Umunyana Rujeje. I'm the Executive Director of Section 27. You have just heard the words from Brian Curran, who is from Concentric Alliance, who have been our partner in the research that we did and have compiled the report with us that we're launching today. I hope you've all had a chance to see the link to the report. It's also available through the Section 27 website, so you can check it out there. So thanks to Brian, who is an expert in consensus building. He said he's sorry not to be here today. I would also like to thank Sasha Stevenson, who is the head of health rights at Section 27, for her presentation of the report, some of the highlights that we've seen. We're all interested in what the areas of agreement are, what the low-hanging fruit are that we can begin to work on. She also outlined the paths forward that we have identified, one of which is to work on some of the low-hanging fruit to see what we can test, how we can begin to do the work of consensus building and understanding of what the health reform needs are. She also spoke about developing a consensus building process around the difficult issues that we know exist because they have been part of the public discourse around NHI, and certainly came out very clearly in the interviews that we did. So we're going to now move forward to a panel discussion. We have some wonderful guests with us today. I will introduce them and then I'll ask them to make some remarks and answer some questions as well from the audience today. We are keeping track of the questions in the Q&A and in the chat, so we'll try to get to those questions. And then we'll have a wrap up from Sasha at the end. So to introduce our panelists, we have Dr. Ayanda Nsaluba, who graduated with a medical degree from the University of Natal and worked as a doctor at Mthatha General Hospital before going into exile in the late 1980s. He completed a Master's Sciences degree with a specialization in health policy, planning, and financing from the London School of Economics, and undertook his specialist training in obstetrics and gynecology. Dr. Nsaluba also holds an executive MBA from the Graduate School of Business at the University of Cape Town. He has served as a Deputy Director General for Policy Planning in the National Department of Health from 1995 to 98, and as DG of Health from 1998 to 2003. Whereupon he joined Discovery Limited as an Executive Director. We also have on the call Sibongile Chabalala, who is the National Chairperson of the Treatment Action Campaign. She is openly and proudly living with HIV. She was diagnosed with HIV in 2000 after a long and severe illness. In 2009, she became a member of the TAC Vosloorus branch. In 2012, she was elected as the provincial chairperson of TAC Gauteng. She's also an honorary fellow of the Steve Biko Center for Bioethics. And lastly, we have Dr. Nicholas Crisp, who I think we all know. He's a medical doctor and a public health specialist. He was the Superintendent General, which is now the HOD of the Department of Health in Limpopo, where he served from 1994 to 99. Dr. Crisp was then self-employed as a consultant and worked in several African countries, including South Africa, Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania. In 2009, he served as special advisor to the Minister of Health, Barbara Hogan. He was intimately involved in the establishment of the National Health Laboratory Services, NHLS, and also worked in the establishment of the South African Health Products Regulatory Authority. He is now working with the Minister of Health on the implementation of the NHI Fund. So I'd like to welcome all of our panelists and ask them to switch on their cameras. And I would like to kick off with Sibongile. I think we all understand that whilst we talk about the right to health being a fundamental human right, and the fact that the users of the health system and the users of the public health system in particular are the most affected, are the most vulnerable, and that all of the work that we do must respond to the needs of those vulnerable communities. So Sibongile, I would like to ask you first, what do you think the key concerns are that were raised in this report? In particular, civil society has been concerned and vocalized concerns around the governance the governance mechanisms in the NHI bill, and also the accountability mechanisms in the NHI bill. And the Treatment Action Campaign is concerned about accountability and has been doing work on accountability on the ground. So what do you think the role of civil society should be in this health reform discussion? Can you unmute yourself, please?
Yes, thank you, Munyana, and thank you everyone who's in the panel and the participants. I think it's very clear what you are asking me, what do we think about what is going to happen, what needs to happen on the ground. And the fortunate and unfortunate part is that in most cases, we are the people on the ground who suffer the most, and we see how people are suffering. And when we talk about health reform, for us as people who are always on the ground and working on the ground, it's something that we see as in now far away from us. But then, as we also the report spoke there about the lack of trust, we've been hearing so many promises from our government and especially from the provincial, the national, local, to say things will change. This is what we are working on. But when you go down to the ground, you see a total different picture, and you see a willingness of change on the ground. Instead of things getting better, things are getting worse. So for us, as we are always campaigning for governance, consultation, and also issue of transparency in the government, this means if really all the partners, all 33 partners who have been consulted and responded well, and when you read the report, you can tell that there is a willingness. But then the question is what we speak or what we're willing to do, able to implement on the ground. So the willingness and implementation are two different things, especially for us who are around. So what we are really interested in as civil society, not all civil society as I need to that, because now we have seen civil society being captured by some part of the government where it makes it very difficult to push for other agendas that affect most people on the ground. We have seen a rise of civil society now that is only interested on the budget and the funding of civil society, other than providing services to the ground. So as much as looking on lack of trust, I think we spoke in the report, it spoke of lack of in these key role players in terms of health reform, but it never goes deeper in terms of each sector. How are they working, how things are. And also I want to Munyana speak quickly about the partnership between private and public, which is something that we've been talking about a lot, and we are not seeing any movement of that. What we hear mostly is just our discussions that are happening, but in terms of implementation, we don't see anything that is happening, which as speakers on the ground, as people on the ground, as patients on the ground, we want to see more of implementation than discussion to say what could be done. What could be done, what has it happened. As I'm talking to you now, I think it's 2 years, if I'm not mistaken, or 3 years, when the health inquiry report was launched and there were recommendations. But up to today, if you can ask to say how many of those recommendations were taken up, none of them. What does that mean to me as a person on the ground? It means we are only identifying problems. We only know what to do, but we are not prepared to do what we are supposed to do. Thank you very much.
Thank you so much, Sibongile. You've brought up so many important issues. And I'd like to traverse the one point that you raised around public-private partnerships, and the fact that civil society organizations want to see those kinds of partnerships working in communities and in health facilities. So I'd like to invite Ayanda and Saluba to reflect on these kinds of partnerships. Ayanda, being from Discovery, which is a big player in the private health sector, do you have a view on some of these public partnerships? And also, can you just say some of the things that you found interesting in the report?
Well, thanks, Umunyana, and thanks to, first of all, just to thank Section 27 and the Concentric Alliance for putting this report together. I think it's a very useful report. Of course, it's always nice to be with my colleague Nick on stage. And Sibongile, nice to meet you. Just to say, I mean, as I said, I think this is a great initiative, Umunyana, and I think fundamentally the findings and the way you've sketched out what you found in these interviews, by and large, to those of us who are active in the health sector, would not be very surprised by what you found. But perhaps I think more than surprise, I think there are a number of things that are quite reassuring. And I think they are reassuring and point us and probably gives us hope that those of us who believe that whatever the challenges that we're facing now and whatever weaknesses we may point at, and which Nick might not agree with on the bill as it stands, but actually I think there is an opportunity for a strategic advance, and for us to really begin to turn the corner, because quite frankly, the current situation of an inequity in the health sector is something that is completely incompatible with the broader mission of building a truly democratic and inclusive society. And I think that's what we should be using as a starting point. The second point is that we should always remember that right from the beginning of the democratic dispensation, what we now call universal health coverage, we framed at that time as equitable access to good quality care. And this is something that we had designed because of the Section 27 in the Constitution primarily, as something that we should all aspire towards. And I think in the course of these 2 decades plus, there are moments when we've made advances and there are moments where we've had significant setbacks. And I think what we need always to look at is try to understand where we've had the setbacks. And that takes me to an important point, that if you look at the analysis, whether it was in the policy paper that laid the foundation for the NHI from the DOH, if you look at some of the strategic plans, if you look at the work that was done with the DBSA, for example, on managerial, administrative, and leadership capacity in the health sector, we more or less have got a good sense of what is not working. And in as far as the private sector is concerned, and I think the MHI report, anybody who would have wanted to argue that the private sector in South Africa is without fault, all you need to do is to look, or without limitations, is to look at the HMI report, because it actually highlights quite a number of things that require immediate attention. So that is the starting point. And then coming to the point that the question that you are raising is that, and maybe just to also say, Munyana, I think one of the things that's encouraging in your report very specifically, and I think in the report you make this point on a number of places. I think sometimes we tend to see some differences as simply cut as if it's public versus private. And I think the report begins to allude to the fact that there would be concerns that are expressed, that shared between people across the public-private divide, as well as concern and opportunities seen across the public-private divide. And I think that then actually helps us to begin to step back and say, but how do we engage in far much more sustainable, productive dialogue for us to be able to move forward? And as a starting point, which takes me to the point that Sibongile is raising about partnerships between the public and the private sector. I think a good starting point is just an acknowledgement that the problem and the challenge we face is bigger than any of the sectors working in isolation. I think we need collaboration, we need partnership, public, private, civil society. And quite frankly, given the experiences that we've had, not necessarily just in the health sector, across the board in South Africa now, I think the more we mobilize and make sure that we encourage and create opportunities for individual agency also to play a key role. And so civil society as a mobilizing tool to make sure that the citizen is actively involved in what is happening. I mean, we've had a number of examples of partnerships that have helped solve seemingly insurmountable challenges in the past. We know that in the past, between civil society and government, there were major, sometimes very difficult points around the HIV/AIDS treatment, and Sibongile will be very familiar with that. And I think sometimes these collisions and these sometimes open doors and lead to points of cooperation, and that is why we can step back today and say perhaps we run one of the biggest programs. Yes, it's not without challenges, but clearly there's been significant advance. And I think a significant part of that advance was the partnership that developed over time between civil society and government. we've just emerged from a major challenge now around the epidemic. Nick and I happen to have been sitting in the coordinating structure on this. Both of us, I'm sure, would acknowledge that this is not a process that was without its own challenges. Some of the things that you allude to in the report in terms of suspicion, self-interest creeping in, all those things were there. But the key issue is that because there was an identification and a shared view that there was a huge threat that was facing our country, it was important for us to hold their hands across the divide and work together. And I believe that, and more importantly for me, I hope that was one of the things that the Department of Health would have taken as a major success, is that it is possible to have stewardship by government, because there's no question that the major direction was mapped out by government on what needed to be done. It is possible for government to play that stewardship and yet mobilizing all our resources available in the country and leveraging the goodwill that happens at a point in time, depending on the nature of the challenge. So I really want to say, just right in the form of introduction, Umunyana, that I think is a very good report, and I think it gives us good pointers. I actually would even take a step and say the recommendations that are put forward are worth of serious consideration. And I think last point really I would like to make is that it's important when we get into major reform, at least that's my belief, that understand that there will be people who travel with you 100% of the way. There will be people who cover 90% of the way. There will be people who cover 70% of the journey. Right. So the strategic choice that you make right at the beginning, do you want to limit the journey to those who only cover 100% of the journey? Or you want to leverage every ounce of support that can be to make the journey far much easier to travel?
Thank you so much, Ayanda, for those points. And I'd like to bring Nick into the conversation and ask about what Ayanda has spoken about and this deficit of trust between the government and, other parties. And to ask you, Nick, whether you see any low-hanging fruit to be able to address some of the reform issues and the public debate issues. We've also spoken about the fact that the lack of trust is related to corruption that we've seen, a lack of accountability from government, some of the big failings of our premier health facilities that are failing public healthcare users. So Nick, in this environment where we've seen corruption, we've also seen austerity, where we've noted the decrease in funding towards health. And what do you think, even on government side, is there some consensus seeking that can happen between Treasury and the National Department of Health, for example, to address some of these issues collectively? Nick?
Yeah, thanks very much, Munyana, and greetings to panelists, colleagues, people who are attending. Thanks very much for inviting me. Thank you for interviewing me. And I've been in the National Department 1 year and 2 weeks now as an employee, and it has been a roller coaster ride of note. But I'm an eternal optimist. I know that there's some in the audience who think I live with rose-colored glasses, but that's what's got me to this point, where I still believe that there's more in common than there is not in common. It distresses me quite a lot when there's deliberate wedge driving that goes on. And unfortunately, even during COVID, we saw quite a bit of that. Behind the scenes, the amount of collaboration is enormous. And in fact, it's been a privilege for me to be a part of all of that. Ayanda alluded to it. In the beginning, we were meeting 3 times a week between a very big group of people in the private sector with us in government, making sure that we got a program going. The private pharmacies alone did 6.5 million vaccinations during this period, including the small pharmacies and so forth. There are lots of examples of huge collaboration and cooperation where public and private dependents were being vaccinated across both sectors, and we learned an enormous amount. We also learned that it is possible to share bed space. It didn't happen as much in practice as we thought it might, but we put the mechanisms in place. So I think there is distrust, and there has been quite a lot of distrust over the years. It's not by any manner of means done away with, but it's less than some people would have us believe. So maybe just talking first of all to the constraints, and then I want to talk about the opportunities that are raised in the report. And I think it's an excellent report. I've also had quite a lot of time to talk to Sasha and others in Section 27 over the period, while I was working on the NHI and the Minister's Office before COVID. So the constraints are huge. And it's been a frightening experience for me to come back into government after more than 20 years. It's a very different place from what it was in 94 to 99. It is extremely rigid and extremely difficult place to work. You've alluded to it in your last comments about the austerity measures. Our budget has been cut, and this illusion that is created that there's new money being provided for COVID vaccine is nonsense. It is done by what they call reprioritization. In other words, carving out money from the budgets to pay for COVID vaccine, 2 billion rand this year is a case in point, and the previous vaccines. The National Department of Health has now signed, and I'm the signatory to that, $480 million loan at a very cheap rate with the World Bank to make it possible to do other programs in government. We've already spent that money a long time ago, and now we are having to account for the ongoing vaccination program, which, as you know, has lost a lot of momentum. So there are massive constraints. We are under pressure from media, from other parties, and Sibongile referred to this as well. Promises made by government to fix certain things. The pressure is to increase the number of nurses and the number of doctors, but the budget is getting less and the unions are demanding higher wages. So in fact, more and more posts are being frozen every year. So the public sector has no chance at all of improving or increasing itself to the extent, I'm not saying there aren't opportunities for improvement, but to the extent that people in the public discourse and in the public space think is possible. I have discovered that there are the Department of Planning, Monitoring and Evaluation, which requires hundreds of reports from us on a yearly basis. Well, maybe not hundreds, but plenty. The Auditor General South Africa, who in my branch alone sends me 5 requests for information on a weekly basis. I have one director busy 2 days a week just answering questions to the Auditor General about things in advance about the NHI, which doesn't even exist yet. Budgeting, we can budget into the future on MTF cycles. So we can't change the allocations of money during a year or even the conditional grants or redirect things like we used to be able to do with some flexibility in the past. Parliament has its own processes, which are political processes, and we as the officials are not allowed to interfere or engage with most of those processes. The Department of Public Service and Administration is the department ultimately responsible for employing everyone, including in the whole health sector. And they are the party that is primarily responsible for the bargaining engagements together with Treasury, who gives the ultimate mandate. So there's a relative straitjacket in being able to tackle some of these priorities. But let's just quickly look at them. I'm not nearly as negative as Brian came across, and I had an opportunity to talk to him a few times. I think, yes, there are low-hanging fruits. Yes, there are suspicions, but the bill does not say that the public sector wants to take over and run everything. It's very clear that public and private providers are an essential part of the delivery of healthcare. In the financing, that's where the NHI is different from the current financing mechanisms. The NHI and the current policy does not see it viable to have 76 medical schemes with over 270 different packages. But we are busy piloting interventions right now as we speak. I'm particularly concerned about Gauteng, as everybody is. It's had a huge number of turnover of senior management and senior staff, and we are very concerned about the continuity of what goes on there. But the bill proposes some ways of overcoming that. And because Gauteng is so important in the provinces around it and the public services around it, and it's got this huge private sector willing to help around it, there are definitely solutions. We have many late night meetings and other weekend meetings and so on with private providers to see how we can plan interventions. But without the money to buy that care, it's the same budget. we are not able to implement some of these really remarkable solutions which we have worked out between us. We do have successes. We have the Health Information Exchange, which private sector, including Ayanda's colleagues in Discovery, have put together. They invited us to the launch. We've been working together in harmonizing the public and the private Health Information Exchange. We're very happy with the collaboration. So in the national sphere, on the second point in Sasha's presentation, ICT is, we have the interoperability framework. We've had 2 major conferences. We have had excellent collaboration with the private sector. And right now, the technical working group on coding, which has finished its work on Friday last week and will be presenting to us during the course of this week, has included public and private sector players. So I'm sure we're going to get some quite useful recommendations. Procurement is a disaster for us, but it's not controlled by the health department. It's controlled in National Treasury, and we're working with them to try and find different ways to do procurement, all kinds of procurement. And in the NHI bill, there's an intention to remove all the medicines and other health products procurement from that process and control it in a completely different way to get better pricing. Infrastructure is controlled by the GIAMA, the Government Immovable Asset Management Act. It's a massive frustration to the health sector. We budget for capital works and we hand over the money to another department to spend on something we didn't even plan. And it is a constant source of tension and irritation in the public sector. We have had plenty of discussions on how to change that, and we have been working with the Development Bank, Treasury, and other parties to see how we can use blended financing mechanisms, turnkey solutions, and others with the private sector. So I agree, that's a low-hanging fruit, and we should capitalize on it. Logistics, huge amounts of our logistics are run by the private sector. During the vaccination program, the entire logistics program centrally and parts of it in the periphery are run by the private sector on contract. And our CCMDD is entirely run by the private sector. We just oversee it. And we also get frustrated with the procurement process there. But without those private players, there would be no chronic medicine distribution. I agree on the health outcomes and indicators. We need common data definitions, a common data dictionary, and the coding is going to go a long way to making that possible. There are lots of exciting things happening between the public and the private sector on how to monitor and measure that. On the HMI reforms, we had worked out what we were going to do prior to COVID, but people have already forgotten COVID, and it's still consuming 50% of my day every day while we try and bed down the integration of COVID vaccination into the health delivery system and so on. We lost 2 whole years of things we wanted to do. I don't think people realize how few managers there are in the public sector. In my branch, we are only 4 managers and there's no staff. My organogram at the moment has no admin officer, no person, PA, none of that. We are busy creating it. And on the 2nd of June, just a couple of weeks ago, the Minister of Public Service and Administration approved the new organogram with 44 posts. Now, if you ask Ayanda in Discovery how many thousands of employees they got, I got 44, and that's a 4,400% increase in what I had before. So it's small steps, and it's putting mechanisms in place, working with the Council for Medical Schemes, with the medical schemes themselves, and so on. So I think that, do we need more dialogue? Yes, we do. It's been excellent, the dialogue during COVID. It's been time-consuming, at times frustrating, as Ayanda said, lots of interactions with NEDLAC and other parties, but absolutely fruitful in the end. So do we need this kind of consensus building? Yes, we do. Are we going to agree on everything? No, we're not. Will we be able to achieve some common ground? Yes, we already have quite a lot of common ground. So I'm in favor. I'm really quite positive about what you have been doing together between the 2 organizations, and I look forward to further interactions. Thank you.
Thank you so much, Nick, and thank you for your optimism. I think in civil society are known also to be optimistic and looking for solutions. I'd like to ask Sibongile, a question that is partly related to one from the chat, which is around the voices. So one of the questions was, being heard is key to consensus building, but while it's necessary, it can't be sufficient. If you are heard, but your voice is subordinated to others in the final equation, it really depends on how decisions are made. And another question was about how to bring in young people into this discussion and debate, including students in medical schools who are going to go into the health system, how to bring their voices in, and of course more of the users' voices. Sibongile, do you have a view on how that should happen?
Yes, Munyana. I think all of us here will remember that some of us being part of the civil society, it's because we are directly affected, and we came to the space because we wanted to make a change. We needed to advocate for our rights, and it was all about us. But then when you talk about youth, we are talking about different level of people and different environment now. As much as they talk, we can talk about them with HIV, but what are their real issues? What is important is to listen to young people to say what are really issues that they need, they are struggling with, and how do we support them? I'm starting this term to say, how do we support them in making sure that they are taking up their issues? Because with our generations, and if you look at the panelists, there's no one who's less than 40 years in the panelists. So there is no youth voice here in a panelist. So you cannot come here as Sibongile, as 46 years old, and represent you young people, because as much as they talk about their issues and listen to their issues, the mistake that we always do is to come up with solutions for them. We don't give them space to come up with their solutions, and their challenges are different from ours. Our challenges was the shortage of treatment, and now is a matter of how do we sustain our healthcare system. But for young people now, they are frustrated. We are talking about mental health issues, about young people who are in school and out of school, who are now dragging into drugs, who are falling pregnant, who are becoming HIV positive now and again. I'm sorry. But then we never, as much as we are always saying we are listening to them, we never gave them a space to come up with their own solutions, to say, we think this can happen, and allow them to lead, give them space to lead and support where we can. And we can come up with our knowledge to say, okay, this is how we fought HIV. This is how we were in fighting government about these issues. But maybe their fights doesn't need government, they need other sectors. How do we bring other sectors on the table? Social development, we hardly talk about it, and other key role players in terms of young people. Young people are struggling with bursaries, are struggling with poverty. We are talking high percentage, like over about 60% of young people who are not working. So the issue of mental illness, the issue of engaging young people, the discussion that as much as we can create a space for them, but we need to give them space also to lead and engage on their own, discussing their issues and telling us to say what kind of support do they want from us, not us offering what we think is best for them. Thank you.
Thank you so much, Sibongile. And Nick, I think that's an offer to you in your 44 posts. I think that you will be able to find some wonderful young people who have the experience of accessing healthcare services and who would bring a lot to the dialogue. So I think that's so important. Nick, do you want to say something?
Yes, very much. So I have a personal thing. I have 2.5 years to go to retirement. I'm useless to the system now. And I need people who will be here for another 10, 20, 30 years. So you're absolutely right. We need to find young people who are enthusiastic, who've got the basic experience that is needed, who are ready to take hold of the future. we are, people of my age, we are out of this by now. I mean, I came out of retirement to do this particular job. I do not need to create a career. I do not need to be here for me or anything like that. So absolutely, our adverts, so we were working on them over the weekend. We'll see how quickly we can get them out. We will circulate through every organization, Section 27, everywhere we possibly can to find people. And they're all professional posts. There are no administrative posts amongst those 44 posts. If we can find young professionals to come and join us in this team, we will be thrilled. Thank you.
That's awesome. Thank you. And I think the idea is that there needs to be more cross-pollination because there's so much to offer from civil society, from business, from the private sector, from the public sector. And Ayanda, I wonder if you would like to come in here as well and give some of the experiences within the private sector, the learnings that you've had over the past couple of years around COVID, and how you've been able to bridge some of the divides.
No, thanks. I mean, first, since this is confession time, also, Nick, having 1062, I completely agree with Sibongile. I think Nick and I, in the next 2 years, we should not appear on television on debates like this any longer. Just to say, I mean, COVID was really a very good experience and a demonstration of what is possible. And I think Nick alluded to this point. And again, not without difficulties at the beginning, not without a need to make sure that there's clarity of roles. The private sector does not usurp the role of government. That government, in the course of COVID, also wanted to make sure the opportunities used to make sure that we bring far much more coherence in the health system. And I think that was all good. And of course, it required a bit of discussion at the beginning. And I will stress one thing, it does help sometimes for these discussions in a responsible way to be held in as open a manner as possible, because then there's nothing as destructive as things that are said in dark corners, when in fact you have the opportunity to raise the concerns so that those concerns can be addressed. Because at the end of the day, if we focus on what we want to see as an outcome, then it should be possible to work ourselves through those processes. And I think in COVID, that's what we did. The second issue is that I think we need to communicate very clearly that both people in the public and the private sector to understand that actually, which is why I made the point that the current levels of inequity in the access to good quality care is completely incompatible with us building a sustainable, inclusive democracy. And I think we can see the ferment in our country already, driven by a variety of issues. And I think it's going to be very important that the same sense of urgency that drove us as we were confronting COVID, because we saw it as a common threat, both across the public and the private, that we have the same approach as we look at the issue around really building and turning the corner in terms of making sure that we reform significantly our health system across the public-private. And I think one of the things that we've lost over the years, which Nick would know, that right in those early years, we also had a firm belief that a well-functioning health system is very critical to ensure the restoration of people's dignity. And I think, again, in this moment of crisis, I think we need to have that. And if we have these rallying calls, I think there's enough people of goodwill across the public-private. I think many people in the private sector know that there will be some changes. And I think sometimes the anxiety is far much more driven by making sure that every step is thought through, precisely because at the same time we could squander a great opportunity and end up with something worse than what we even have today. So that's not out of, there's nothing that says that cannot happen. And I think all of us, cool heads are necessary, all of us to try to focus on what the end point is. The end point is really to focus around the citizens. And I think COVID taught us those, as Nick says, I mean, there were capabilities. And I actually think also people in the private sector began to understand far much better some of the constraints. some of the constraints that people in the public sector are working under. And secondly, also remember that people in the public sector also had to make sure that in as much as we're focusing on COVID, there's also the other parts of the health systems continue to function. So there was no limit of time, and that is why I come back to the point that I hope the colleagues in DOH would also have taken one important message, that when they set the goal very clear and hold everybody accountable to that very clear goal, it is possible to marshal quite a lot of goodwill and support across the public-private. And as Nick says, I think that was by and large achieved during the time when we were working on COVID. The next point that I would really like to raise, I think even as we discuss, I think to me, certainly the most important thing as we talk about the reform going forward and leveraging these partnerships across the public-private sector. And I think we should just make sure that let's not pursue one track. NHI is the policy objective. It's very clear. The bill is very clear about what we want to do. But there are also parallel processes that need to go on at the same time. And some of them are around issues that Nick is speaking to about public sector strengthening. Some of it looking at what we can do together across the public, civil society, and the private sector. And thirdly, also to make sure that there's better alignment between the private sector and the public sector. And again, that's where the HMI report comes in, because it begins to bring in that alignment. Because part of the challenges that we have in South Africa is that the two systems have been allowed too much to run far much more on parallel tracks. And therefore, invariably, then the perception develops further that the one can only be strong at the expense of the other. Whereas we need to better align them so that the strength of one part of the system fits into the other, so that we can minimize the periods of learning, take lessons from across the public-private, those things that work, use them far much more to make sure that the system moves forward.
Thank you so much for those comments, Ayanda, and for the passion behind the comments. I also we're drawing to a close very shortly, but I do note that Nick wanted to respond to some of the questions in the chat. Nick, I'll give you a chance to do that now.
Okay, thanks very much. So yeah, I think there's a very useful question from Brian Matibe asking about leveraging research work and work out of academia and so forth, business schools and so on. We do receive quite a lot of reports, and in fact, we commission work from schools of public health medicine, business schools, and so on, to assist us with various things. We don't have the capacity for health economics assessment and health technology assessment in the department, not at the level that we would like to have. So we often do commission that kind of work, but it's very deliberate work. The more esoteric work and where it's sort of looking at what goes on in other countries around the world and so on, it's interesting. But, you know, study visits and study tours to other countries and academic reports on that is for the past. We've been spending 20 years doing that. Now we need to concentrate. What we are busy with right now is the Colleges of Medicine, School of Public Health or Public Health Medicine, which I'm a member of, is busy putting together a package with me where all the registrars, certainly the 3 universities here in Gauteng for a start, will rotate through my office, and I will have a joint appointment with the Gauteng department or with the universities so that there's a teaching environment. HPCSA has approved the department to do that. So we'll start to get some academic inputs from schools of public health medicine into the department. 4 of the 44 posts are for specialists in public health medicine. So if we have the registrars, rotating specialists coming to work in the department, we can start to professionalize at least the National Health Insurance branch in the Department of Health, and people will start to see the value of having academia. Last comment, the NICD, the NHLS, as you read in the introduction, I've worked very closely with them since foundation, have unbelievable academics. I mean, really the network is second to none, and we are unbelievably proud of what they've done during COVID. Without them, we would not be able to do what we do. So instead of duplicating that capacity in the Department of Health, we deliberately farm out to the work. to the SAMRC, to various schools within the faculties and the health sciences faculties, and to the NHLS and others. So I think there is quite a lot of dovetailing, and if there's a specific reason behind Brian's question, you must contact me. Thank you.
Thank you, Nick. I'm going to take one last question from Mark Haywood. He says, we should know now that 1, elite contracts don't work. 2, social contracts need to be built with active involvement of communities. And lastly, be linked to an agreed program of urgent health reform. Nick, I'll ask you to respond to that and to give your final remarks, and then I'll ask the other panelists to also conclude. Thanks.
Yeah, thanks very much. I'll keep it short because I do get a chance to talk to Mark quite often, and he knows I think like that already. So from the space that I work in the health department, I absolutely agree. It doesn't help to have everybody pitching out like me in jackets and ties and sitting around boardrooms age 60 plus making decisions. And there was a question, a very good question asked by Anonymous in the Q&A about how are we going to fix the public health system if we don't use the public health system. So those levels of engagement are supposed to happen at community and provincial level. And by the time you get to the national level, it's almost too esoteric and too high level. There is a provision in the National Health Act for a National Health Consultative Forum to be held annually. I was told now, since Minister Pashla was appointed as minister, that the last one was in 2015. So what we are doing at the moment is we are saying it's okay for the president to initiate a health compact, but this is the health minister's mandate and responsibility. The Minister of Health is not the Minister of the Public Health Department or of the National Department. The Minister for Health for the country. And that minister must take the initiative, call the forum, listen to people, engage, put together whatever appropriate technical working groups there are, so we can really understand what's going on. And that is supposed to be duplicated at provincial level. So we're busy, now that COVID has slowed down, we're all starting to get our lives back. We are busy with the planning to make sure that this happens. But that is a very good question, absolutely agree.
Thank you. Thank you so much, Nick. Sibongile, can you give your concluding remarks, and then Ayanda? Thanks.
Thank you very much, Section 27 and the partner to make sure that this conversation is happening. But I would like just to emphasize the issue of health market inquiry recommendations, because I think it depends for them, and we were really excited to say they will be implemented. So, Comrade Nick, unfortunately, this stays with your responsibility, and also Comrade Ayanda, to say we make sure that those recommendations are taken up and implemented, so that at the end of the day, as the recipient of healthcare system, irrespective of private and health, because whether you are poor or you can manage, even as poor people, we always try to have at least of a medical aid, so that you can be able to get few of the private healthcare system, so that things will be better for you. Although at some point, at the end of the day, you run out of funds, you don't know how to do, you have to pay at the end of the day. So which also strain more people on the ground. It doesn't mean that 16% of the population that are using a private healthcare sector can afford to use private healthcare sector. But if there are reports and there are recommendations and everyone is agreeing with those recommendations, let's try to implement them. Let's work together in that, including civil society, so that we see what works, what doesn't work, and always have those conversations to say, this is what we have tried, this is what worked, this is what didn't work, how can we improve from one point to another? So that will also address issues of the whole society of South Africa. And when we talk about reform, we'll be talking about something that it will affect everyone, and everyone will be involved. Thank you very much.
Thank you so much, Sibongile. Ayanda, last word.
Umunyana, thank you very much, and thanks to the two colleagues. Maybe let me start with a point that Nick raised, actually, which is about the role of the health minister. And I think Nick has really hit the nail on the head on an issue I feel very strongly about, and I think it's a sensitive issue. the National Health Minister is the Minister of the Health in South Africa. He's not the Minister of the Public Health Sector. And I always find it very disheartening and very uncomfortable when a health minister appears to be completely, feels that his hands are tied, he cannot deal, and all that he can do when he's got so many tools available to him is actually to stand on the margins and scream and complain about some things that he does not like in the private sector. So I really think the more we can move in the direction of seeing responsibility for the public and the private, the health minister driving those and understanding that much as on the public sector side probably he's got responsibility around provision also in addition to financing, he also has responsibility, as was pointed out in the health market inquiry, to make sure that the regulatory framework that exists for the private health sector is supportive of the general effort towards the achievement of the objectives in Section 27. So that is the first thing. It's a pity we don't have time. I see Leslie London is raising some important probing questions around. And I think just the point to make is that when it comes to the accountability and the governance in the system, I think that is where I move back to the issues of citizen, the agency of individuals and mobilizations of the citizenry to understand what to expect from the system. Because there's a very big difference between, writing on a piece of paper what the accountability mechanisms are and making sure those are adhered to and people are the ones driving those. And as we move towards a more integrated system, a far much more collaborative system, and with the sort of mindset that Nick was alluding to about the role of the national minister, then it should be, it is part of that to define very clearly what those levels of accountability are going to be across the public and the private, and how all of us therefore feed jointly toward the attainment of the objectives, that policy objectives that we have. So, but apart from that, really just to make the point again, I think there is no lack of people of goodwill currently in our country. And I think many people are concerned about a lot of things that are happening in our country, the direction that our country seems to be sliding slightly towards. And we all can see the dangers of that. And I think this is the time for all of us to awaken, be driven, even if it's enlightened self-interest, to understand that. And I think across the public-private divide, there are many people who really want to make sure that this country works and that our health system is a fundamental, strong underpin towards our human capital development and also for the stability of our country. So I really think that responsibly handled, these policy reforms and all of us, and I think the portfolio committee should apply its mind and be seen to have applied its mind to all the inputs that are made. And then let's be able then to move forward and look at paths that ensure that we can unite as many people as possible so that we can achieve our objectives.
Thank you. That's a wonderful way to end the panel discussion. I would like to thank all of the participants, everyone who joined us. Sorry we didn't get to all of the questions, but I thought it was a very interesting and informative debate, an important one that is, as Nick has said, these are the dialogues that we need. And these are the moments where we can come together and talk about the levels of extremely high goodwill and interest in addressing inequality in our country and in the health system in particular. Everyone spoke of the deep inequality and the divide between the public and private sector and the need to bring those closer together in order for people to be able to access quality healthcare services, regardless of whether they can afford to do so. So thank you all very much. I'm going to hand over, I'm sorry we're a bit over time, but Sasha will wrap us up, and thank you so much.
Thanks so much to all of our panelists and the great questions that they got. So as Sibongile said, the health reform debates can seem quite abstract to many people. But the reality in the public health system.
So maybe Sasha can put a video off. We're losing your signal, Sasha.
healthcare. And the plan, the public and private health systems. So
Sorry, Sasha, we lost you. Can you begin again?
they're bigger than not. They come. Yes, can you hear me now?
Yes.
Okay, great. Apologies for that. I'm moving to somewhere where I hope the internet will be better. So I think what's clear from the conversation today is that there are health system problems across public and private, and both the problems and the opportunities span the public and private divides. We shouldn't assume that all of the answers are in the private sector. They're certainly not. They come from across the system. And as Sibongile noted, the willingness to implement is different from real implementation. There's a real urgency and a hunger for urgent implementation. I think what's encouraging is that all of the panelists describe the findings and recommendations of this report as reassuring. There's an opportunity to advance and to turn the corner on the problems we're experiencing in the health system. So how do we do it then? The report proposes two paths. The first is, or the one path is about implementation now, to test options for contracting and referral, to implement national health projects, to orient the system towards health outcomes, and to implement key health market inquiry recommendations and procurement reform. Some of the technical aspects of this are already under discussion, as Nicholas described, but there's a lot more that we can do, and that there is some surprising agreement on in terms of urgent implementation. And the second path is about consensus building on some of the wicked problems. As much as we talk about willingness to collaborate, there are some things that we clearly do across the system disagree on. And ensuring that process includes those beyond the elite, whether it's the elite in government or in the private sector or in civil society or in academia, that kind of inclusion and hearing is important. And there are many structures that provide opportunities to do that, like clinic committees and hospital boards and CBOs, etc. And so we really hope that this report can move the health reform forward. No one's interested in talking for the sake of it. We know from this report that there's real appetite for immediate action and for further collaboration and consensus seeking in the interests of ensuring access to healthcare services. And we're looking forward to engaging further with stakeholders from across the system to push these recommendations forward. So thank you to everybody for joining today. We're very grateful that you've made the time. We're grateful to the panelists and the participants in the research and to all of the attendees of this launch. And please do reach out to us if you're interested in working with us on moving this forward. Thank you, everyone, and have a good day.
Thank you very much. Bye. Cheers, Sibongile. Cheers, Ayanda.
Thank you, guys. Thanks, Nick. Thanks, Sibongile. Thanks, Sasha.
Thank you.
Thank you, guys. Thank you.